one of the big pros about being a nurse is you can nurse anywhere in the world. You just have to get registered. So, if I want to come and nurse in the US, which I did complete my NCLEX exam. I just didn't end up coming back again, stayed here. But, like if you were to come to Australia, Kevin, you would just have to sit your board exam here. If I want to go and work in the UK, I just have to register and sit an exam there, the same. So, one of the pros of being a nurse is it opens the world up and you can have a career anywhere in the world. And you can have such diverse experiences as a nurse that no other profession would ever give you.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey everybody, Kevin McFarland here from the Art of Emergency Nursing, and thanks for listening to the podcast. I appreciate you being here. I always remind you to leave a rating and review because that's what helps other people find this podcast. So if you haven't done so already, please do so. I want to take a minute and read a review that I just got that really just blew me out of the water. Now, this review came in from Apple Podcast, and I can't read the name, but let me tell you just the title first of the review. The title says, "Sparked a light inside me I thought I lost." The review says, "This podcast reminds me of why I became a nurse. Working in the ED, I've often found myself burnt out and actually wanting to leave the bedside. This podcast reminds me it's not nursing itself that burns me out, but the dynamics surrounding nursing. This podcast reminds me of why I am a nurse, and specifically an ED nurse. The stories resonate so deeply, I find myself near tears at times. Keep up the good work. You'll always have a listener in me." I can't read the name. It's got a little icon or something on there. But this review just blew me away. This validated everything for me. So I can't thank you enough to the person who did this. Gosh, I can't thank you enough for this review. This review means everything to me. Thank you so much. So if you want to make me feel good, hopefully I'm making you feel good, leave me a rating and review. You can do it in Apple Podcast or any of your podcast players. But please do so. I really appreciate it. In today's episode, you're going to hear from one of the nurses who actually inspired the International Nurse Series that I just completed. She's an amazing nurse all the way from Australia. I had the pleasure of meeting her in Austin, Texas at an ENA conference a few years ago, and we have kept in touch since. She's been a nurse, a clinical nurse specialist, a nurse leader, and is now busy trying to protect the citizens of her state from COVID. She's an amazing nurse who actually just announced that she's running for the ENA Board of Directors. You are going to love this episode with my friend, Vanessa.
Well, hi everyone, I'm Vanessa Gorman. You can probably hear from my accent that I'm from Melbourne in Australia, and I've been an emergency nurse since 1996.
Wow.
So I have worked predominantly in my state of Victoria in Melbourne, in Australia, but I've done lots of different roles that sort of have, I think, allowed my base of emergency nursing to really springboard me off into some really exciting roles that might include, working on cruise ships with P&O in the past and, doing event management and all of that sort of stuff, as well as, we can talk about it a bit later, but some of the COVID-19 experience that I'm working in at the moment. I think I probably always wanted to be a nurse. I was a pretty sickly kid, spent a lot of time in hospital, and my dad was an intensive care paramedic, which in the US you would know as probably an intensive care EMT. So they're essentially a doctor on the road. They can intubate and do lots of different things. So I kind of grew up with that in my blood, so to speak, of running around ambulance and fire stations and listening to my dad's stories and being excited, and sort of never wanted to be anything else but a nurse. But it's funny looking back at the career thinking I've done so many other things and be a nurse. It's really it's weird watching the career.
So why nursing and not paramedic?
To be completely honest, my dad really pushed me hard to become a paramedic, but I think he always sort of was happy that, I had my own career path and my own journey to follow. And here's a little unknown fact, but I actually was a trained opera singer. So my actual aspiring career when I was much younger was to be on the stage. I wanted to play on Broadway and I wanted to sing musical theatre and be all around the world. But I could do that. But the caveat from my parents was I had to finish my nursing career first. had to finish my nursing degree first.
Okay.
And then I could go off and be an opera singer if that's what I wanted to do. Never went back to singing opera again.
You're like, this is too much fun.
Yeah.
You're like, this nursing thing's going to work out. It's going to be fun.
Yeah. So, and then it was a couple of years after I was sort of in my nursing career that my dad's like, I think you should still be a paramedic. Why don't you have a look at being a paramedic? And my honest comment back to him was, Dad, that is way too corny to have a dad and a daughter paramedic. Like, just can't happen. And the other reason I can't be a paramedic is because when I've done ride-alongs before, and I'm sure it would waver over time, but whenever they turn the lights and the sirens on, I just can't stop laughing. Like, I literally just giggle like a little 5-year-old because I'm so excited to be in the ambulance flying down the road at 120 150 kilometers an hour, and yeah, I just can't stop giggling. So that was one of the reasons I couldn't be a paramedic.
Yeah, she's gonna be way too happy
Yeah, way too happy about putting the lights and sirens on.
How funny is that?
Yeah, but I was just talking before about my experience living and working in the US, and one of the reasons I came to work on as a camp nurse in America was because after my first year out in nursing, I decided I couldn't be a nurse anymore. It wasn't for me. And
really?
Yeah, so I decided to take this camp nursing position in the US and got on my very first ever plane at the age of 20 to go over to fly to America for 21 hours when you've never been on a plane before. That was my very first flight, to go and just use that as an opportunity to decide if I actually wanted to be a nurse anymore, if I actually needed to find a new career path. Had a pretty traumatic, what we call a graduate year here in Australia. Worked on a very large oncology unit, bone marrow transplant unit, and we had a pretty unsuccessful year, and we were losing all of our patients. And then towards the end of the year, they realised there was a cross-ventilation problem. We were on the same floor as the HIV ward, and there were all these terrible viral infections going on in these highly immunocompromised people, and we had cross-contamination, which meant that all of our immunocompromised oncology patients were passing away, unfortunately. So,
oh my gosh.
Yeah, but camp made me decide that actually, no, I loved the emergency side of things, and I was going to come back to Australia and be an emergency nurse, but not before I came back and did a second year at Camp Greenville in North Carolina.
So why there? Why all the way to America to be a camp nurse? Was it just for the adventure?
Yeah, I think just the adventure. I think it was just something freaky that came up, I think, on TV. Have you ever thought about being, working in the holiday camps in America? We don't have anything like that here in Australia. We don't do summer camp at all. When Aussie kids have their summer break, which normally goes, for around 5 or 6 weeks in the summer they have off, we don't send them away to summer camp at all. So Aussie kids just, run around the backyard and we go to the beach, and our parents don't fly to Europe for the summer. So that doesn't happen. So I just saw it and I'm like, I might go and have a little bit of a look at this. Maybe this is what I'm looking for, a bit of a change of scenery. And so I didn't choose to go to the camp that I was allocated to. It was literally an allocation. So, but I still talked to probably over a dozen people from that camp, still to this day. And I was last there in, what would it be? Nice. Would have been last there in 1997, 98, and still to this day, still talk to people, have lifetime friends, and
that's all. I find one thing with nursing is, like, I now have friends all over the world from being in nursing and involved in ENA and everything else, and like, you stay friends a really long time with nurses, and you find people you have a lot in common with, and like some of my best friends in the world are nurses.
Yeah, and I think it's because, you know, we're a pretty collegial bunch at the best of times. Doesn't matter where you are in the world, we're always happy to network and make friends or meet new colleagues and share stories and experiences. And yeah, I absolutely agree.
Yeah, that makes it cool. So, but that kind of lit your passion for nursing, and then and that's when you decided to become an emergency nurse.
Yeah, so came home to Australia and was really lucky to get a position in an emergency department. And in Australia, if you want to stay working in an emergency department, you need to do postgraduate studies. So obviously we have our base registration, which is off a Bachelor of Nursing. And then after the first year, where you sort of go through a transition program and supported place in the ED, pretty much you have to make the decision, are you going to stay and do your postgraduate studies, or are you going to sort of drift off into do something else? So pretty quickly I knew this was for me and enrolled in my postgraduate certificate, and then went on to complete the diploma in emergency nursing and critical care. And then, yeah, I think just the doors that opened after doing that was just incredible. I've been incredibly lucky to have the experiences that I have. And, you know, when I coach young aspiring emergency nurses, or even just, you know, general nurses, you know, I quite often share my CV because it's so diverse on the different roles that I've done. You know, through originally helping set up clinical pathways for, say, DVT management in our state. So, you know, got to join in as a project officer and work with our Department of Health, and then going on to help set up one of the very first short stay units, emergency short stay observation units in Australia.
Wow.
Yeah, back in the late 90s. So yeah, but definitely, you know, really fell heavily in love with emergency nursing and everything about it, and had a bit of a trauma passion as well. I never got the opportunity to work in our what we call a level 1 trauma centre that sort of takes all the helicopters and stuff, but I've always worked on sort of large metropolitan fringe hospitals, and I think the trauma out there is so much more exciting. You know, I've had stories in the past where you know, it's not unusual that you get some mates and their friends being attacked by a bull in the paddock, and they've just decided that it's actually quicker to throw him in the back of the ute / pickup truck and drive him the 20 kilometres to the emergency department. So all of a sudden you've got frenzy at the front door, and when you go out, you've got an unstable pelvic fracture and a spontaneous pneumothorax and a flailed chest to deal with due to a massive crush injury, who's had no pre-hospital care at all. The first thing is, how do I get him out of the back of the truck? That's the first thing. But I think that's the part I've always enjoyed about, you know, working in some of those more sort of fringe metropolitan services where you can actually really put your emergency nursing skills to the test. And, you know, having that little bit of a passion for trauma, you know, I first got in contact with ENA, I would have been late 90s. That was sort of when I first reached out to find out about the organisation. And that was because I wanted to run a trauma nursing course for our emergency staff in the ED. Nice. And so at the time, the TNCC was the accredited course to do, but we didn't really run it in Victoria. It was only really run in our state of New South Wales, near Sydney, Australia. So I had to sort of reach out to ENA and the TNC instructors and actually bring them down to Melbourne, and ended up, you know, you had to have a minimum amount of participants. So I had to coordinate that across 4 different hospitals and bring in trauma nurses from nearby so we could undertake this course. And that just, again, you know, undertaking that course and learning more about that trauma management led me into becoming an international trauma coder. And I, you know, used to, you know, code all the traumas that would be reported into our state database, wow. And sort of, you know, give them their ISS scores and do all of that sort of stuff. So yeah, really exciting. But that was probably my first taste of coming into ENA and starting to really network out and realizing what a great profession that I was in, and the amazing talent and expertise around me was, you know, it was just like this little pot of gold that you could just tap into. It was really exciting as a junior ED nurse.
How exciting. How exciting is that to bring in a course that is a good course and like makes a huge difference in your care, and bring that to your small, kind of smaller town ED. You know, I know here in the States, we have a lot of small EDs that they see a lot of like real trauma that, you know, there's a one freeway that goes, through their town, and their hospital happens to be there. And so they may not be a level 1 trauma center. By golly, they're going to get that trauma patient. They're going to
Definitely.
fly them out as soon as they can, but they're going to get that trauma patient. They're going to have to get them stabilized. And that
Yeah.
happens in what we call critical access hospitals all over the country. Are some of those, small, like level 3 and 4 trauma centers all over the country.
Yeah.
Like they get real honest to goodness trauma.
Yeah.
It's
You
not
feel a
just
little
the
bit
level
sorry.
ones.
You feel a little bit sorry for the level 1 tertiary centres, because they're already pretty much, cleaned up, scooped up, and delivered on a nice little silver tray for them.
Yeah.
Here you go.
Yeah, the flight nurse.
The collar's on. We've braced this, the pelvic splinters on. We've stopped that arterial bleed in the lower ankle from the compound fracture. Here you go. Whereas, you're right.
Yeah.
All of those smaller centres, even some of our regional trauma centres, they have to do the real trauma work and then package them all up and put them on the helicopter to bring them down to Melbourne.
Oftentimes, when I worked at a level 1 trauma center, and we were the only level 1 trauma center in the state, and we would get people from all over the state. Same thing. They'd come in, packaged and a lot of stuff already done. And but what they did is they spent a lot of time training these smaller centers to say, okay, we know you're going to get the trauma, so let's teach you how to take care of these traumas.
Yep.
So,
and I've been involved in a lot of that work in my state in Australia around even, we have a state trauma system that we used, and, probably unlike the US, even though we are roughly, we're a pretty big country, we're really restricted by this tyranny of distance. Like, not a lot, there's, yes, cohorts that live in and around the city and the coastline, but then you might have to travel, the next biggest town might be 5 hours away.
Yeah.
And there might be nothing really in between. So we have this real tyranny of distance. And one of the things we've really focused on, and I've been a part of some of this great work, has been taking that state trauma system and actually figuring out, how do we use that to train all of our regional centres that actually do the trauma, so that they know, we're working within the golden hour, don't sit and play too long, get on that retrieval phone call as quick as you can, patch up what you can, and then get them out of there as quick as you can. But so it's been a big piece of work that we've had to do in Australia, to try and upskill our regional centres a little bit more.
Yeah, I know certainly in New Mexico it was the same thing, because we had great distances between, with nothing in between these great distances. So I would guess that you guys probably have quite a bit of flight programs that go for, helicopter, pick one, either helicopters or small planes that take people from one place to the next.
Yeah, so we have obviously, the helicopter's a bit restricted in its flight time, so it can sort of normally, a town that might take, say, 2 hours to drive to, they can normally fly there out of Melbourne, go pick the patient up and bring them back without a refuel. Like that, we can get up to the snowfields, which is roughly a sort of a 3 to 4 hour drive from the city of Melbourne. The helicopter can get up there and then come back, and then pretty much everything else apart from that is fixed wing. So, and predominantly run not only by our ambulance service, but also the Royal Flying Doctor Service, which is quite, renowned and respected here in Australia. They do a lot of great work, particularly, in our true remote areas, like through the Northern Territory and the upper parts of South Australia, or the outer reaches even of New South Wales and Western Australia, where, you truly do need fixed wing to get anywhere, because, you could drive, it's in Western Australia, for example, it wouldn't be hard to drive for 8 hours and not even go through a town.
Wow. Holy cow.
Yeah.
Okay.
So, there's really big pieces of Australia which, are not inhabited, and there's literally one road. That's it.
One road, just going through, nobody stops.
Just going through.
Yeah. Wow. So in all your roles, where do you think you found the most success as a nurse?
Well, I think probably, if I sort of summarize the roles that I've had, I've been a camp nurse, been an emergency nurse, I've been a clinical specialist in the emergency department, I've been a nurse on a cruise ship, I've been an associate unit manager in an emergency department, I've been a care coordinator in an emergency department, I've been the state trauma coordinator for a hospital, and I've been a nurse unit manager, which is predominantly where I've landed over the last sort of 10 years, predominantly has been in nurse management. If you ask me where do I think I've been the most successful, I think success is measured differently, isn't it? Depends what you're looking for. I feel like I've had a bigger impact on the next generation of nurses. And for me, I identify very much as a transformational leader. So I measure my own success because my team's successful. So for me, if my team's successful, that is, they're professionally developing, they're getting great positions, or they're getting really amazing offers and opportunities to, either, go work on a cruise ship or go be the state trauma coordinator. They're getting great opportunities. That makes me feel really successful. So I feel like I've had most of my success in my management roles that I've held. But then on a personal note, I think when I was a clinical nurse specialist, and I think I felt very successful in myself because I was going leaps and bounds in my own professional development. I was becoming trauma competent, and I was an international trauma coder, and I was doing this and I was doing that, and I was flitting here, there and everywhere and doing all these amazing things. So personally, I felt really successful within myself. And I think that's the role I really, really wholeheartedly enjoy. And now that I've had a bit of a break from the clinical and the management of an emergency department, it's funny how COVID is making people reset all over the world. Like, you just hear the same stories all over the world. And it's really made me think about, what are the priorities? Where do I want to go? What's in my future? And it's funny because this for me has provided a reset to say, maybe it's okay not to be the manager and to have the title, which I think I chased for a little while, that I was looking for that title.
Yeah.
And that level of respect that comes when you're the manager of a unit. But I think my reset is, I actually really just want to go back and be by the patient's bedside and actually get some personal success back for me again, and look at other ways that I can still be in leadership positions. Maybe it's not the management stuff I'm really seeking so much now, but how else can I still be influential and be a leader, but have a bit more personal feeling of success?
I think one of the things I found very similar in being in education, where I'm not in leadership anymore. I'm not in the director role, but doing education. And I find that being like, I feel like I'm a little closer to the bedside, and I feel like it's influence. I have more influence over maybe practice than maybe even as a nurse leader. Like, I think you have kind of an unofficial influence, which is really nice.
But I think you're probably devaluing the influence that you're having on the next generation.
Yeah. And that's exactly it. The influence you have on the next generation. Like, I have a group of 16 residents that I'm just getting started in the emergency department, and we're just teaching them how to be an ER nurse, how to think like a nurse, how to act like a nurse. And you're like, and just seeing their eyes go, oh, okay, this is what you meant when you said this. And you're like, yes.
Yeah.
It's
you see
just
the penny
amazing.
drop.
Yeah, exactly. It's just amazing. It's amazing to see. It's so good for my soul. Like, it just makes me feel good. So
yeah. And I think there comes a point where that's what you need to start searching for. What's good for your soul versus, like I think when I spoke at the conference 2 years ago in Austin, around, what does our future workforce look like? It was very much reflecting on, for people to want to stay and be an emergency nurse. And I think when I did the roll call and got sort of everyone to stand up and say how many years of service they'd done, there was not many standing with me that had done more than 25 years in emergency nursing. Like,
it doesn't happen much.
That knowledge isn't there anymore. Like, people are burnt out and sort of move on. And I think that the other bit that happens, particularly in Australia for nurses, there's always this push to, the next promotion, where are you going next? What's the next level up that you're doing? What does that look like? But each level up actually moves you further and further away from nursing.
Yes.
I think when I was the manager of, one of the busiest EDs in our state at the time, given a $30 million budget to oversee, but no budget training or no accounting or finance training. Here's $30 million. Please answer to why you didn't meet the budget every month. I'm like, I don't know. I don't understand the budget. But, you're sitting there, you get handed all these extra responsibilities, but actually you don't need a nurse to do that job. You need a business manager.
Yeah.
So then all of a sudden you sit there and reflect, okay, well, I already have a master's and 2 graduate diplomas. Oh, do I need to go back and do a master's of business administration? Maybe I need my MBA now. And then you sit there and go, well, do I need 2 masters and 2 grad dips, or will I just go on this way and get a PhD? Like, so there's just this forever push of, next level up. But each level is don't be a nurse.
Yeah.
It's really, it's interesting.
I think we see the same thing here in America. Now, do you guys use nurse practitioners in Australia?
Yep, we do. Very limited.
There's a big push. I think this is just my observation in America. There's a big push for people to get away from the bedside, become a nurse practitioner. And so many people want to go from what I call zero to hero. They want to start as a brand new nurse and they want to be the nurse practitioner like tomorrow, or just as quickly as they can. And it's like one of those, it's like, but the value you have of your experience is a valuable thing. That experience is what's going to make you a clinically strong nurse practitioner.
Yeah, absolutely. When we teach triage, triage is a skill that we all learn, but there's something to be said about the fact you can't learn intuition. I used to sit there and train people to work at triage. Triage is kind of, apart from being a floor coordinator, because I love doing jigsaw puzzles. So I think, I always see running an ED is like doing a massive jigsaw puzzle for the day, and you just hope you get all the pieces in the right place. But when I wasn't doing that role, my other main role was to be a triage nurse, and absolutely loved it. But I would say to people, too. I know it might not make much sense to you now, but I can tell you that after you finish your training, and maybe in another 6 to 12 months' time, once you've consolidated all your knowledge, you are going to tell me that the grey of a diabetic patient in a crisis is a different colour grey to a cardiac patient in crisis. Because I said they both look really sick and they both look grey, but I can tell you they're 2 very different greys. And you can pick the cardiac from the DKA out the back of the line. So I think, just that, getting back to the fact that, we can rush all these young nurses through as quick as we can and get them all the qualifications. And we have that same problem here in Australia. The new workforce now believes if I go and do my postgraduate certificate in critical care emergency nursing, I just invested $10,000 in my career. So within 6 months, I should get a $7 an hour pay rise. So I'm going to be a clinical nurse specialist within 7 months of finishing my course.
Wow.
But everyone else with lots of experience and years under their belt would certainly sit there and argue, I don't think anyone's a clinical nurse specialist within probably the first 3 to 5 years of actually learning emergency nursing, because you're still developing and growing and understanding everything over that time period. Yeah,
absolutely.
But this young workforce just say, I have a qualification, you pay me duly for it.
Yeah. Now, does nursing pay well in Australia?
Yeah, so a graduate nurse, so that'd be first year out of university, they'd be on a base of about $72,000 to $75,000 a year plus penalties. So they'd be up around probably, $85,000 to $90,000 in their first year.
That's pretty comparable to.
Yeah, it pays pretty well. And then, all the way up to, I don't know how it works in the US, but there's always this sort of running joke. Most associate unit managers who still work shift work get paid more than a nurse unit manager. And it's something that we've actually been really fighting hard for with our union in the state of Victoria and in Australia, has been, how can that be? How can we actually say or plan for succession if we actually can't pay nurse unit managers more than their associate managers are getting paid? So there was a point where when I first became a nurse unit manager, I think my base was about $92,000, $95,000 a year. My associate managers were earning about $4,000 to $5,000 a year more than me.
Wow. And you're like, okay, someone's doing something wrong here.
Yes, yeah, it's me. Whereas now the base rate in Victoria for a nurse unit manager is $115,000 a year. But now we've tried to work it on a tiered system where it depends about the complexity, because that was the other issue. When I was the manager of, the busiest emergency department, 60-bed unit plus a 25-bed observation unit, so 85 beds that I was managing 175 physical head count, which equaled 107 FTE. I was getting paid exactly the same amount of money as the person who was 15 kilometres down the road in a 6-bed ED with total staffing of 20 FTE.
Yep.
So we fought pretty hard to say that, well, that's not okay. And And, you know, for myself, you know, I have this bit of a motto / mantra, and that is, you know, we all need to be our own walking billboard. So part of my coaching and I think the things that I take on as a leader within emergency nursing is I want the next generation to look at myself or the role that I hold and go, oh my gosh, I so want to do that. I would want to be her.
Yeah.
And I know that I get compensated well. It's a role that's exciting, you know, so hopefully now what we're showing that next generation coming through is that, you know, the people before you have fought pretty hard. So if you do run the busiest emergency department in the state with 85 beds, you will be compensated fairly versus if you are running the 6-bed unit. So there's a bit of work going on. So I think nurses get paid pretty well in Victoria. We get lots of shift penalties, and it depends whether you work privately or in a public, because obviously we have Medicare and the public health system, which is that universal health system for every Australian, but we also offer private in healthcare as well. So the pay differences can be a little bit different between public and private, but yeah, I think we get paid pretty well.
That's good. It sounds pretty comparable to America. And, you know, I think a lot of nurses probably right around that 95-ish a year. And I think that's probably a not unheard of. But the nice thing about nursing, and I don't know if it's the same in Australia, the nice thing that I always tell people about nursing is you are 100% in control of your own income. If you want to work extra and make extra money, there's plenty of opportunity to do that. There's plenty of opportunity for overtime. Or if you want to work 3 days a week and then have 4 days a week to go travel the countryside, you can do that too. So
and we're the same here. We probably have, I don't know, I've spoken to a few US you know, friends and colleagues that sort of give different horror stories about expectations on shifts and lengths, and, you know, especially over, you know, the COVID period. I think we've really seen this come to light around the excessive amount of hours that people are working. Probably in Australia, and look, some might argue, you know what, we're the country of laid back Aussies. You know, we're all about the work-life balance if you aspire to that philosophy. We like having lots of holidays. We have lots of public holidays, and we like doing our 5 days a week, but our unions are really strong in advocating that we don't work excessive overtime. So, you know, there's different rules around how much overtime you can do each week. If you have a second job, you have to declare that to your employer so that they can monitor your fatigue. So there's sort of different sort of union laws, particularly in nursing, that I guess would probably prohibit some of the practices that I see from afar that happen for US nurses, where they might do, you know, I've heard a horror story of, you know, like I think 11 12-hour shifts in a row. So
you're like that's not
that
even
would
safe.
be unheard of. It's not even safe.
Do you guys do 8-hour shifts, 12-hour shifts, or what?
So predominantly in Australia, we do 8-hour nursing shifts in the ED. Our intensive care units still go with the 12-hour model, but it's been talked about off and on, even through our professional body. The College of Emergency Nurses has weighed in as well. And I think when you look, if you put a fatigue lens on things, you know, unlike the ICU, that is essentially still it is a pretty controlled environment. You know, asking people to work in a truly heightened emergency response for probably more than 8 hours starts to become unsafe. You know, and I think, you know, we've got different rules in place now where, you know, it could be, you know, it's not unheard of that people might be asked to stay back and do a double shift. So they might end up working sort of a 15, 16-hour day, but then in lieu of that, they get a paid day off the day after.
Nice.
If that happens, to make sure that we give them that time to recover and come back to work and be a safe practitioner. I think we're pretty risk adverse here in Australia.
That's good. That's a good thing. That's a good thing. I know, most nurses do 12-hour shifts in America, and it's not unheard of to do 16-hour shifts, like pretty regularly, or, you know, you certainly see a lot of people do, you know, 4 12-hour shifts a week and not bad. And I lash at it. And I always laugh when someone tells me, oh man, I'm so burnt out and I'm just so tired of work. And I'm like, how much are you working? They're like, I work like 6 days a week. And I'm like, well, that's why you're so burnt out. Try scaling back on that. Like, try not working.
So in Australia, the base full-time hours per week is 38. Okay. Some organisations might still offer you a 40-hour week, but then you get an accrued day off once a month. So you get a paid day off once a month, in lieu of you working the extra 4 hours a fortnight.
Okay.
Yeah.
All right.
Yeah.
Interesting.
Again, we're pretty laid back down under.
I like it. I like it.
Work-life balance. I hate that saying, just so you know.
What was the saying?
I hate the saying work-life balance.
Work-life.
Everyone's looking for work-life balance.
Yeah, certainly. That is always the, we say it all the time, and as nurses, especially nurse leaders, we're really bad at it. Like,
yeah. I don't like the saying because it infers that work is negative and life is positive. And I think that sends a really conflicting message for me to our next generation of workforce, if that's how they're processing things, is that work is negative and life is positive. And I'm trying to get a balance between negative and positive. Yeah. But if you love the work that you do, why is it negative?
Yeah. And
so I think we need to challenge people on even some of those basic sayings and actually how that impacts on that next generation of workforce, let alone ourselves. Like, it's very rare you'll ever hear me say it. And then if people do sort of make that comment like, oh, yeah, but I'm trying to get work-life balance, I will openly come up and say, what are you looking to balance?
Yeah.
Yeah. Why is work negative for you? Are you not doing the right job? Maybe you need to look for a different job where work is really positive for you.
Yeah. I mean, I've been lucky that I have, for the most part throughout my career, I have loved what I do. Like, and it makes it easy to get up and go to work every day. Like, granted, there's some days that I get up and I'm like, oh God, today's going to be a day. But for the most part, I'm like, I got to go to work today, but got to do something all day, right? Got to do something. Exactly. So sure, I'll go to work and not complain too much, for the most part. But, every now and then you're like going, but
yeah, and that's usually when you look back and go, oh, I haven't had holidays for a little while. That's why I feel like I'm a bit flat. I need to have a holiday.
Yeah, you're like, I just need to spend some time off.
Yeah. What do American nurses get for time off each year?
I'm trying to, so I don't even know.
So in Australia,
I don't take enough time off.
So in Australia, nurses, in our enterprise bargaining agreements that we all sign, essentially it's a minimum of 6 weeks off a year of paid leave.
Wow.
Yep. If you don't work, so if you work sort of a more Monday to Friday role, then on top of that 6 weeks, you also get your public holidays. Some of those people that just do Monday to Friday work might only get 4 weeks, but they can purchase extra leave. But most nurses in Australia would be on sort of having and be very used to having 6 weeks off of paid leave every year.
Nice. And and I can't remember the last time I took 2 weeks off. Like, I really honestly can't. Like, for a long time.
Probably because of COVID. What's the point of taking leave? Like, there's nowhere to go. There's nothing to do.
Yeah, that's true. It's a good point. With COVID, like, where are you going? Like, you're gonna take a day off and stay at home and sit on the couch. Like, so
that's what I've done every day.
Perfect. But yeah, like, I can't remember, like, very, very rarely have I taken, like, do I take 2 weeks off? Like, truly, like, I most of the time for a long time, a lot of my time off was, going and doing conferences, going to run around doing this education and that education. And I'm like, I'm using all my vacation time to just work more,
to keep working.
Like, like, what am I doing? So and then every now and then I'll take some time off, and I might be like, let's take some time off and go do something. I'm like, okay, yeah. So speaking of COVID, how has COVID gone down in Australia? How has it been for you guys there?
I actually just was reflecting on that a little bit the other day, and I was actually going to reach out to the education people for the conference for ENA coming up, because I think one thing that Australia has experienced is like no other country in the world. We haven't had the explosion of cases. We haven't seen any demand on our healthcare systems. Our government has taken a highly conservative approach to it, and we locked down our borders and truly did become an island at the bottom of the world very quickly. Even to our little co-island, New Zealand, we even shut off to them.
Wow.
So I think the experience that Australia has had with COVID is like nowhere else in the world. We've been so lucky. We still have had deaths, and unfortunately that was mainly related to an outbreak in the community, and it led to aged care outbreaks. And I think I think on our very worst day, I think we had maybe 800 new cases a day for the whole of Australia.
Wow.
So that was our very worst day. So that's nothing compared, and as I sort of spoke about before, we have a population of 25 million people. So I guess what's New York State? New York State sits about the same population of all of Australia. So
I think so.
yeah. So
I'll double check
I
that.
think
But
we've been very lucky. Life is very much normal, and all our sporting events are back to full capacity.
wow.
Yeah, so we're even planning on putting 90,000 people at the massive MCG football ground in about a week's time for one of the biggest Australian rules football games of the year. So yeah, everything is pretty much back to normal, but we did some pretty hard lockdowns, particularly in my state of Victoria. We've been the worst affected in Australia, and we've seen the most deaths and the most cases. But what that I think means is that we have the most knowledge and experience and can support the rest of our states of Australia when there's little outbreaks, or mainly what we're seeing now is we are still having Australians coming back home, so to speak, that might have been stuck overseas, and those are coming into hotel quarantine. So things that we're seeing now is mainly related to breaches in hotel quarantine, where there's either a bit of transmission in the hotel, or there might be a bit of a community leak and a worker has tested positive. But we're pretty good at shutting things down pretty quickly now. So what happens in Australia now is if there's a community case or a couple of cases, we go into a really hard 3-day or 5-day lockdown, and pretty much no one moves. The government shuts the whole town.
Just shuts down.
Just shuts everything down. All the shops close apart from essential supermarkets and petrol sort of stations, and you just do a really hard snap lockdown, and that puts that breaker circuit in the community transmission. So so I think we haven't. I think it's sad that we have to watch what the rest of the world are going through. And particularly for me, my work with the International Advisory Council with ENA, and I've got that many friends in Germany and Spain and Denmark and Norway, the US, and even Canada, like reaching out to them, trying to be supportive, but you don't know how to send out that support. We're so far away, and I don't truly know what they're going through, really. So, for me personally, I think I've had a really interesting evolution through COVID. So I started on the clinical coalface as an emergency department manager, and had to, set up my department and make sure I was ready to receive, COVID patients, and how would we separate them, and do all that clinical interface work. And then for the last 9 months, I've sort of got scooped up, and I was brought into the Department of Health here in Victoria, and I'm now the Senior Operations Manager for our COVID-19 response for the whole state.
Holy cow.
Essentially what that means is I oversee around 300 contact tracers and medical staff who all do amazing work in shutting down these transmissions as quick as we can, and put strategies in place to, let people know as quick as we can if we've got something going on in the community. But yeah, so that's what my role is now. And people are like, oh, don't you miss the emergency nursing side? Honestly, I don't even think I could do this job if I didn't come from an emergency nursing background. And there's 3 of us that sort of share this role. The other one is an intensive care nurse of many years, and the other one is an ED nurse as well. So I think to do the role we're doing, it's like running the ED. It's highly reactive work. We can sit here some days and not really do anything, and then all of a sudden a positive case will come through the system, and you've just got to go from 0 to 100 within the space of like 30 minutes, and you've got to have all your actions in place, contact tracers on board, interviews happening, exposure sites listed, shut this down as quick as we can, with lots of media pressure and health minister sitting above you saying, come on, how much longer? What are you doing now? So it's very reactive work, but absolutely love it at the moment.
That's awesome.
Yeah.
That's really awesome. And how are the vaccine efforts going there in Australia?
Yeah, we're not doing so well on the vaccine front. Unfortunately, we have a supply issue, and I think there's 2 schools of thoughts about why we have supply issues. Number one is we are a COVID-free country, and we have been now for I think it's like 45 or 50 days we're up to, where we've actually had no COVID in the community.
Without even being vaccinated. That's amazing.
Without even being vaccinated. Yeah. So we've still got return travellers testing positive, but they're locked up in a hotel room, can't do anything. We've had actually no community cases for near 50 days in Australia, and our whole population of 25 million people. So the supply issue, I think, is other governments and powers that be around the world seeing, well, why would we send vaccines to a country that doesn't have COVID over, say, India, that had 250,000 cases yesterday? That's where we need to, put our attention to. But, there's lots of politics being played here. We were clearly blocked by the EU to not receive Pfizer vaccines. That pushed us to only having supply of AstraZeneca. Now AstraZeneca has been essentially banned in Australia. I was explaining before, we just had a death of a 48-year-old woman who died within 48 hours of this blood clotting syndrome after being vaccinated 2 days ago. And, now the backlash of that is we have all this media hype about how terrible AstraZeneca is, but we still all know, with our medical brains on, that it's such a rare complication, but now we have no consumer confidence. So even in my state, we were vaccinating about 7,000 people a day, and yesterday's numbers we were down to sort of about 700. So we've dropped by about 90%, and I think that's got to do with consumer confidence. But we've got we should have vaccinated around 3.5 to 4 million people by now, and we've only vaccinated just over 1 million.
Wow.
So of our 25 million population. So we have a long road to go. Our government has basically said they don't expect Australians to be vaccinated, everyone have a first dose by until sort of maybe even this time next year, or February next year, which is limiting in the respects of, if the rest of the world starts opening up for business and international travel, what does that look like for Australians who can't even get a vaccine?
Yeah, for sure.
Yeah.
For sure. Wow, that's interesting. It's interesting how different that experience is.
Yeah, but we have plenty of PPE.
That's good.
We have plenty of. I watch all my friends around the world, and they're all screaming out for N95 masks, and I'm like, oh gosh, we could probably send you 1,000 boxes of masks. That's probably one thing, because we always have had really good PPE supplies. So even when we were having 800 cases a day, there was not an overwhelming surge on emergency departments, but every emergency department was very well stocked with PPE. And, we were putting people at the front door. We put up hazmat tents at the front of emergency departments with, ventilation that sort of, tried to limit anything getting inside of an ED. And so that's been one positive thing out of it.
That's good. Wow. Holy cow. Yeah, it's interesting how different it is in different places. So
yeah,
I'm glad you're getting it. I'm glad you're getting it under control, and even without vaccines. I mean, that just shows you the power of the community mindset and being like, no, we're closed. We're not doing this.
Yeah. Well, it's funny now because our Prime Minister has started talking about travel bubbles opening up. So we are, I think as of tomorrow, where you can travel freely between New Zealand and Australia without having to quarantine. And he's starting to talk about, potentially Singapore might be the next travel bubble that we have. And it's interesting watching, social media, and people are like, no, just keep us closed. Keep the rest of the world out, because we don't want to do lockdowns again. Lockdowns are tough, and people losing their jobs are tough. So it's funny because you're right. The community is actually sitting there saying, no, keep the rest of the world out. We're fine down here. Leave us alone.
You're like, we're good. We're good.
We're good. We're good.
Interesting. Holy cow. From your time, your little bit of time in America, and from your friends in America, what do you think are some of the biggest differences between being a nurse in America versus being a nurse in Australia? What would you guess?
Drug names. Just to keep it light. Seriously, the drug. I look. 2 years ago in Austin, Texas, I was given an amazing experience, and I spent a whole day teaching in the trauma labs.
Oh, awesome.
So for me, that just absolutely confirms the principles are the same. It doesn't matter which country you're in the world. ABC is always ABC.
Yep.
Trauma management, and people that get really excited about traumas and like, oh my gosh, I just want to be a trauma nurse, and I'm like, actually after a couple of years, trauma gets pretty boring and mundane, because you just got to follow the same algorithms every single time, once yes, you might see some weird and wonderful injuries, but after a while, that fractured pelvis is the same as the last fractured pelvis, and you know how much blood they're going to lose, and you're going to watch their HB. But I think the main difference has to be realistically the drug names. I can quite often come over and I'll just start rattling off how we would say it in Australia, and like you guys might call it Tylenol, and we'll call it Panadol. So they're the brand names. They essentially do the same thing, but the drug name is actually still different.
Interesting.
So your Tylenol is actually what we use and we call as aspirin.
Oh, really?
Whereas, so because I think is it acid? I can never say it.
Acetylsalic
Tylenol?
acid.
Yeah.
Well, no, acetylsalic acid is aspirin.
Yeah. So.
And then acetaminophen is
Tylenol.
Yes.
So paracetamol is the equivalent of Tylenol here in Australia.
Okay. And I can't remember the name of the IV Tylenol. Do you guys do the IV Tylenol?
We just still call it IV paracetamol.
Okay. I can't remember what it's called. I think it may be, that sounds a little bit familiar. I'm gonna look it up.
You're gonna Google that. So look, I think, when I worked in the US, that was probably the biggest hurdle to overcome, was, getting used to the drug names and the dosages and stuff and how different that was. And I would think if a nurse wanted to come and nurse in Australia, that would probably be my biggest tip, is like just study up on all the drug names that you can, because it's probably the hardest thing. It's going to be a little different, but the IV cannula is still going exactly the same way. So do the catheters. You still administer medication via the same routes. If you really look at it, basic nursing 101 is the same, whether you're in Australia, Indiana, or Bhutan. Like, it's all the same.
All the same.
It's all the same.
Care is care. Like it's all.
Care is care. Yeah, exactly.
So I think that's I think that's true. So I think that's a very true point. That one of the things that I've realized, and even though our governmental health systems and cost and all that stuff might be different, like it's all just care. For nurses, it's just the same stuff. So yeah, exactly. It's and that's, to me, that's a good thing. To me, that's kind of a cool thing to be able to see. Like, here I am, I have a colleague who's half a world away, and same thing. But I think too, when when you're my cousin's daughter wanted to talk to me about whether she wanted to be a nurse or a pharmacist, and when we talked through the pros and cons of each roles, one of the big pros about being a nurse is you can nurse anywhere in the world. You just have to get registered. So, if I want to come and nurse in the US, which I did complete my NCLEX exam, I just didn't end up coming back again, stayed here. But, if you were to come to Australia, Kevin, you would just have to sit your board exam here. Yeah. If I want to go and work in the UK, I just have to register and sit an exam there, the same. So, one of the pros of being a nurse is it opens the world up, and you can have a career anywhere in the world. And you can have such diverse experiences as a nurse that no other profession would ever give you. That's absolutely true. I'm sure that's absolutely true. I say that I haven't done it, but of course, and that's cool. That's really cool. And I think the other really cool thing is nursing isn't nursing as we always got told it was. You don't have to be Florence Nightingale for the rest of your career. So nursing now is education, management, leadership, practitioner, independent practice, nursing. And I don't know how it is, and I think we're probably very similar, but one thing that's really evolved over the last probably 15 years in nursing in Australia has been the specialisation. So for you to be a general med or a general surgical nurse these days is actually pretty rare, because after you do your graduate year, and even in your graduate year, you have to choose general medicine or surgery, and then you have to choose a specialist rotation. So you get two rotations. And like the ED is a rotation that you can go through in your graduate year, so you can have a bit of a taster. Yeah. But it's interesting, over the last 15 years, it's so rare to just say that you're a general medicine nurse now. Yeah. Because if you sit there and if you put 20 nurses in a room, I bet you every single one of them, no, I work on respiratory. I'm working liver transplant unit. I work on HIV. I work in drug and rehab.
I do ED. Everyone's got a specialty now, and that's just that course of medicine, isn't it? Like we sort of streamline and segregate people by diagnosis now, or by their anatomical system issue.
Yeah.
So
you're like, hearts go on this floor.
Yeah, hearts on
livers
level
go
5.
over there.
Yep.
Yeah.
Lungs on level 4.
Yeah.
Trauma and ICU on level 1.
Yep. Exactly.
Yeah.
Every hospital in America, I think, does that to some degree too.
Yeah. But it's interesting. It would be interesting to go back and sort of reflect and do a journey on what's the evolution of nursing been with this evolution in this type of medicine around the world, of this sort of real specialty medicine. And like you say, hearts go on level 5 and lungs go on level 4. And, what's that done and meant for nursing? Have we de-skilled the ones that can actually kind of those jack of all trades?
I think in a lot of places I would say yes, but I think emergency department is a little different.
Yeah, I would agree. Probably EDs are the only true now jack of all trades.
Yeah,
you can deal with every system issue.
As Jean Prale says, she knows the key portions of a lot of different things. So she knows the key portions of being a cardiac nurse and the key portions of being a respiratory nurse. And I love that, because I used to say, my experience was a mile wide and an inch deep, and it's it's more than that, but certainly you get to see a little bit of everything. So one of the things I was telling these nurse residents I'm working with now is I was telling them, like, the EC is a very practical type of nursing. I mean, we get to know a little bit of everything, and I was teaching them some of the things we were talking about, and I was going, okay, you may not actually do this at work, but this is just kind of a nice skill to have, like, to know how to do this. Like, we were teaching, I was teaching splinting, and I was like, okay, let's talk a little bit about splinting. And granted, for the most part, the physicians are going to be doing this in our particular organization. Particularly, it's going to be the physicians doing it. But here's what you need to know, because this is just kind of nice to know, because your friends are going to come, your friends and your neighbors are going to come to you and be like, oh, you're an ER nurse. You would, of course, know how to do this. And you're like, maybe.
See, in Australia, we're the reverse. So predominantly in EDs, the nurses do just about everything, and the doctors only do the high-end stuff.
Really?
Yeah. So nurses will plaster and splint.
Yeah.
Some nurses are trained to do suturing.
Yeah.
I often laugh back and look back. I remember when I was a much younger ED nurse, and I was working in a sort of a high dependency area of the ED. We just did lots of cardiac work, and anyway, we kind of just had our pattern. The patient came in, got them undressed, they had their ECG, someone whacked a line in, someone did the bloods. We kind of like nurse initiated everything.
Yeah.
We would even get to the point where we'd write up the blood slip and just wait for the doctor to sign it, have everything labelled, ready to go. And I remember this junior registrar walked in. He's actually a really good friend of mine now, and he's actually one of the most senior cardiologists in the state at the moment. And I remember him coming to me, and he's just like, I said, okay, so this patient came in, this is their presentation, this is what we've done. And he just sit there and he threw his pen across the desk, and he's like, well, what the hell do you want me to do then? And I said, I don't know, look pretty and sign your name at the bottom of the form. And still to this day, he still reflects on that comment. He goes, you know what? In the ED, I actually got a really rapid appreciation that the nurses will either make or break me as a registrar. So don't piss them off.
Yes.
And, and absolutely like recognize that we're all pretty advanced practitioners. We will initiate a blood gas if we see the patient's clearly hypoxic, and we will get the BiPAP machine out and start them on, pressure support ventilation if we know that that's what they need. So whether or not that's something that's a bit different in Australia in the ED is that nurses have great scope of practice and, are highly encouraged to initiate a lot of care that's probably life-saving most days,
Yeah.
We're normally the ones going to the consultant at the front of the door going, this is an anterior STEMI. Do you want me to call the team or are you?
They're like,
yeah.
Can I look at the EKG? You're like,
no,
if
not
you
really.
want to.
I'm telling you, it's a STEMI. Like, let's call the team.
Yeah, you're like, if you feel like you need to.
Yeah.
Interesting. That's interesting. And one of the things I found and I work in a teaching facility now, and that's why the nurses don't get to do all those things, is because the doctors are doing that. But I remember even as a technician, I worked as a technician at a teaching hospital, and as a technician, we used to do all the suturing. We used to do all the suturing, and we were trained to suture everything from simple scalps to complex facial lacerations. And
Yeah.
we would learn to sew like a plastic surgeon, and we would sew side by side with the plastic surgeon and like keep up with them. Just because we got good. We just did a lot.
Yeah.
Like I've sewn more faces than I can remember. And then here I was with a high school diploma and like an EMT certification, and I'm doing all these crazy procedures. And then the next thing you know, I was teaching it at the med school. Like the med school's like, hey, well, you know how to do it. Why don't you come teach the doctors? And I'm like, sure,
See
yeah,
one,
let's
teach
go.
one. See one, do one, teach one.
See one, do one, teach one. So I was like, sure enough. So sure enough, next thing you know, I was doing the med school suturing lab every month for the med students coming in,
Wow.
and they'd be like, oh, are you one of the attendings? And I was like, nope, I'm one of the technicians. Like I'm sitting there going, I don't even have a high school diploma. I have a high school diploma and that's it.
Yeah.
But it was like, but if you knew the skill, do the skill, like do it. So,
Yep, exactly.
and I appreciated that. That was kind of a cool thing. So one of the last questions I always ask my guests is a question called 3 things. And this is the hardest question. And I should have warned you about this, and I didn't. Give me 3 things you think every emergency nurse should always remember, and 3 things they can just forget.
Oh, 3 things I should always remember. The first thing they should always remember is don't judge a book by its cover. And probably for me, that one is don't let your thoughts or your preconceptions of what you think that person is saying to you sway your decision making, which actually might take you down a really adverse event pathway. So I think never judge a book by its cover. Always listen to your patient's story. And with a little caveat underneath that, paramedics aren't always right. So my story behind that is that, just very briefly, I had a paramedic wheel a woman in once saying, 51-year-old lady, severe onset lower abdo pain, no past history, fit and healthy, spasmodic in nature. He had dismissed her as being, a bit of a sook, and that she was sort of banging it on a little bit, didn't even give her really much pain relief. Saw her have her onset of pain, then watched the pain subside, went over, because I really didn't trust the paramedic and what he was telling me. 3.5 minutes later, I delivered a healthy full-term baby girl, a disclosed pregnancy in a 51-year-old. She didn't know she was pregnant. She thought she was going through menopause.
Holy cow.
So
imagine her surprise.
Yep. So always listen to your patients and don't always believe the paramedic is my second prior take home.
Okay.
And probably my third, you must always remember as an emergency nurse, is the minute that you don't love going to work every day is the time to step away.
Yeah, absolutely right. Now, 3 things for an emergency nurse to just forget. Like it's not a thing. It's not don't even think about it.
If you think you know it all, you don't. So forget it.
Amen.
Forget the haters. You're always going to have people who are going to tell you that you're not good enough or you're not doing it fast enough or good enough. You need to forget that and just stay true to yourself.
Love that advice.
And the last thing that ED nurses should forget, that's a hard one. Just trying to think, what's the last thing I'd just say? Just forget all about that. Oh, I'm trying to think. Because I've got little things I'm like, no, but you wouldn't want to forget that. Look, probably the thing that I would say, the last thing that you just need to forget is when you walk out the door, you do need to forget what happened that day. You need to try and compartmentalize your work from your life and not let that come into your life. So, I think part of protecting yourself and having longevity in our careers is very much sometimes you've just got to forget what happened at work today. and leave it behind, go away, get some headspace, and then come back and love the job that you do.
Sometimes that's really hard to do though, huh?
It is really hard to do, but I don't know what else to tell them to forget, because I'm someone who'll be like, don't ever forget that. Like, keep that one in the bank.
It's hard to, there's certainly plenty of days I'd love to forget, and plenty of days that I have forgotten. But sometimes it's hard. Like you get the bleed over from one to the next, from same thing. Like one of the things I told my residents recently is like, if home life's a mess, like work life's not going to get much better, because you're going to have a hard time turning one off and the other one on. So if work life's a mess, then if work life's a mess, then you're going to feel that at home too. Because you're going to go home and be like, I hate my job. I hate this. I hate that. And you're like, what? Like there's got to be, it's hard to just switch between one and the other, but if you can, to some degree, it will help.
Yeah.
But
and
it's
I think
hard.
everyone has their own little tricks for that, haven't they? Like it's either, I think particularly in COVID, one thing I always did was I always got changed out of my scrubs before I left work. And lots of people don't do that, particularly in Australia. It's quite often that you'll still be in the supermarket watching people running around in their scrubs. And I'm just like, oh, for God's sake, like take that off. But, that was one thing for me that I've predominantly done a lot throughout my career is, and that for me, it's kind of like that physical, I'm removing this layer. This is what I was for the last 8 hours, but now this comes off. I go out in my work clothes, and so everyone has, I think, their own little tips and tricks on what they do, whether or not it's like as soon as I get in the door I go for, or I go for a run before I go home from work, or I go do this or do yoga or whatever it might be. But yeah, it can be the simplest thing, and for me it's always just been just take your scrubs off before you leave work, because that means work's done now.
Yep. I like that. That's a good that's good advice too. Just be like, okay, shed that layer and now you're somebody else.
Yeah
I like that a lot. This has been so much fun. I can't thank you enough for doing this with me. This has been a great interview. Finally, we finally get this together.
I know. I can't believe it.
It's so fun. And this is the latest I've ever done an interview. I usually do it earlier in the evening. This is the latest I've ever done.
What time is it in Texas?
It is almost midnight.
Oh my gosh, you need to go to bed.
Oh, it's no big deal. It's no big deal.
Just about to have afternoon tea.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.